Hello, I'm Robert Hinchliffe, editor of BJS British Journal of Surgery. I'm here to tell you about the February 2018 issue of BJS. I hope you all enjoyed reading the special issue on cancer surgery in the genomic era. The editorial team would like to extend our thanks to all the contributors who made the issue possible, and a special thank you to Professors Malin Sund and Des Winter who oversaw the project. I think you will all agree it's a really great issue packed full of important contemporary data and providing important glimpses into the exciting future of cancer surgery. And now, turning to the February issue, the theme is quality of life, something highly relevant to all involved in healthcare, not only patients and their carers. Our leader this month comes from Joe Church, representing the Patient Liaison Group, Association of Coloproctology of Great Britain and Ireland. Jo very eloquently provides a patient's insight. She gives her a perspective on some of the papers in the February issue and sets them in some sort of context. Fundamentally, she stresses the difference between health status, or the ability or inability to perform a specific task, and quality of life, that being the impact of the inability to perform those tasks on the individual. Interestingly, Jo makes the point that surgical expectation of outcomes does not necessarily reflect those that are important to patients. In this issue, an analysis of the EASY randomized clinical trial deals with the impact of defunctioning ileostomy post-rectal resection for cancer. Although early closure of stomas appear to result in better surgical outcomes, the positive effect reported by patients was negligible. In this issue of BJS, there are original articles and systematic reviews and meta-analyses on quality of life in endocrine surgery, esophageal surgery, hepatic, breast, vascular and colorectal surgery. There are papers on the effect of screening for surgical disease in asymptomatic individuals and a comparison of patient-reported outcome among those undergoing transhiatal and transthoracic esophagectomy. Professor Muller's group from Heidelberg, Germany, explores the effect of metabolic surgery on the microvascular complications of diabetes. Although metabolic surgery is the most effective treatment for obese patients with type 2 diabetes regarding glycemic control, it is unclear whether the incidence or severity of microvascular complications is reduced. In a systematic review of meta-analysis, they demonstrate that surgery appeared more effective than medical therapy for the overall prevention and control of microvascular complications, although the effects on neuropathy appeared less clear. It will be interesting to speculate the comparative effect of these therapies on cardiovascular outcomes, something which is highly relevant to patients with type 2 diabetes. As surgeons, we are perhaps too often focused on attempts to improve outcomes by changing operative technique or perioperative interventions, and yet many of our patients die not of the disease we are attempting to cure, but prematurely from cardiovascular disease. Interestingly, in this issue, two papers focus on just that problem. In the first paper, Van Haalst and colleagues from Utrecht demonstrate the significant burden of deaths attributable to cardiovascular disease in those with intermittent claudication and critical limb ischemia. And the second paper from the Karolinska Institute focuses on both all-cause and cardiovascular mortality risk after treatment for hypothyroidism. In that paper, surgery appeared to offer improved overall survival and a reduction in cardiovascular deaths, especially in men. These papers underscore our need as surgeons to be aware of the risk posed to our patients from cardiovascular disease and to be aware of available medical therapies to mitigate that risk. And in this issue, there was a multi-center randomized clinical trial from Japan in patients with resected bile duct cancer. The trial compared adjuvant gemcitabine chemotherapy versus observation for the primary outcome measure of overall survival. I wonder whether you can guess the outcome. Now, are you a trainee or surgeon who has had a recent interesting case? Perhaps one that confirms or challenges surgical dogma or is just plain old interesting? If so, why don't you consider sending it to BJS to form the basis of a snapshot quiz? In this month's BJS, there's an interesting case of long-standing intestinal obstruction, the cause of which is relevant to most general surgeons. A final word of thanks for those helping with the Spanish translation of manuscripts. BJS now has a massive readership in Spanish-speaking countries, and a very significant conversation is taking place on social media in those countries. Well, that's all from me. I hope you enjoy the February issue. Thank you for listening.